Stop using the EKG to diagnose your patients. Let me show you why. I'm going to throw an EKG up here, take a second, look at it, formulate a diagnosis and a plan. That's how you do it in school, right? Now, some of you might have looked at this EKG and known exactly what it was. You are the minority. The rest of the people looked at it and went straight to ACLS. So they noticed it's a bradycardic rhythm. There's some T-wave inversion, whatever that means in this scenario. So they're probably thinking of atropine or pacing, and none of that is necessarily the case. Let me explain. Every diagnosis is arrived at through a formula, believe it or not. You get this plus this equals this. Just like in mathematics, formulas have orders of operations. If you do anything out of order, the answer comes out wrong. In medicine, in pre-hospital medicine, I believe there is also a formula. Rather than PEMDAS, it's called PHET, P-H-E-T. In truth, it's called PHET-C, patient information, history, exam, testing, and changes. And changes brings you back to the beginning. Any changes in the condition that don't support the direction we were going makes us reevaluate. This is a circular order of operations, but it needs to be done in this way. Let me tell you why. If you look straight at this EKG, your brain's gonna go straight into cardiac mode. The best way to illustrate why you shouldn't is to tell you about this patient using the PHET-C model. So let's do that. So we'll start with the patient. We have a 44-year-old Caucasian male steel worker. He's been a smoker for 10 years at a pack a day. History, hypertension, high cholesterol. Recent history, he picked up a heavy object at work, passed out, woke up, seized, and now he's unresponsive. Let's get to our exam. So skin, warm, dry, okay? No trauma, nothing obvious here. Vital signs, pulse is 30s, respirations are 8 and irregular. Blood pressure is 200 over 110, O2 is 99%. His BGL is 112 milligrams per deciliter. That's 6.2 milliosmoles for the rest of you guys in the world. And of course your test and EMS is gonna be your EKG, which you've already taken a look at. So for anybody who felt like this was cardiac in the beginning, do you feel like it's cardiac now? Probably not, right? What's wrong with this patient? That's right, lifting that heavy object caused a vessel to burst in his brain when his blood pressure skyrocketed during the strenuous task. And now he's had what looks like an epidural bleed, right? Because he went unconscious, he had a brief period of lucidity, now he's seizing. That EKG is a result, it is the living embodiment of Cushing's reflex with elevated intracranial pressure. Dr. Virchow strikes again. If you don't know about the triad of Virchow, learn about it. It's really good. Moving forward from there, the C would be any changes you see in condition, and if it didn't support the original diagnosis that you arrived at. And you can just run this in a loop the entirety of the time you have contact with the patient to make sure that you're considering things from every angle. As you add more history, you readjust your formula, but remember your initial encounter. You should handle it in that order of operations, especially when you are the intercepting paramedic, because when people have been on scene for a while, very often, the first thing they want to hand you is their EKG, right? Because that's the thing you can read that they can't if they're not functioning at paramedic level. Very easy to get tunnel vision and get distracted there. So every patient encounter, approach it with the correct order of operations. If you don't like PHET-C, design your own. This is one I designed. I've used it for years. It's great. All right, guys, get out there and practice.